All right, thank you. Our next talk is a comprehensive approach to the management of patients with hypoplastic left heart, analysis of 76 patients. It will be presented by Dr. Bleiweis.
Dr. Kaushal, Dr. Mary, members and guests, thank you for the opportunity to present our work on a comprehensive approach to the management of patients with hypoplastic left heart syndrome and analysis of 76 patients who underwent their initial surgery at our institution between 2015 and 2021. We have no disclosures. Some patients with hypoplastic left heart syndrome and related malformations are at high risk for Norwood or hybrid palliation. We have developed a comprehensive approach to neonates with hypoplastic left heart and related malformations designed to maximize survival and optimize the utilization of donor hearts. The purpose of this presentation is to review our experience with all 76 neonates with hypoplastic left heart syndrome and related malformations undergoing their initial neonatal surgery at our institution between 2015 and 2021 inclusive. At the University of Florida, our 56 standard risk patients underwent a stage 1 Norwood procedure. Their diagnostic data, age, and weight are shown on this slide. And our 9 high-risk patients with important risk factors other than major cardiac risk factors underwent a hybrid stage 1. While 8 high-risk patients with major cardiac risk factors underwent a hybrid stage 1 procedure and a concomitant ventricular assist device insertion. This slide depicts our approach with a flow diagram. Again, our standard approach, standard risk patients underwent a stage 1 Norwood procedure. Our high-risk patients with important risk factors other than major cardiac risk factors underwent the hybrid stage 1 procedure. And these risk factors include such things as Turner syndrome or severe necrotizing enterocolitis, even frank perforations. And our high-risk patients with major cardiac risk factors underwent the hybrid stage 1 procedure with a ventricular assist device insertion. The rationale for this approach is that some patients with hypoplastic left heart syndrome and important cardiac risk factors are really high risk for Norwood or hybrid palliation, and that primary cardiac transplantation offers the best option for survival in these challenging neonates. However, as you've heard, waitlist mortality must be minimized. 8 of the 76 neonates in this series underwent a combined primary hybrid procedure plus a VAD insertion. All 8 of these patients presented with anatomical and/or physiological features associated with increased risk for conventional univentricular palliation with the standard Norwood procedure. 4 had large coronary sinusoids with concerning distal coronary circulation. 2 presented with refractory cardiogenic shock and multi-system dysfunction, and 2 presented with heart failure, 1 with heart failure and associated end organ dysfunction, and the other with heart failure and severe wide open tricuspid regurgitation. Here's an example of an angiogram of one of the patients with mitral stenosis and aortic atresia with large coronary sinusoids and fistulous communications between the left ventricle and the coronary circulation. There's no opacification of the left coronary circulation distal to the fistula on this injection, suggesting compromised flow, and this patient also had decreased function. Here's another example of an angiogram in a patient with mitral stenosis and aortic atresia with large sinusoids and multiple fistulous connections between the left ventricle and the coronary circulation. For hypoplastic left heart syndrome, our hybrid VAD approach includes application of bilateral pulmonary artery bands, stent placement in the ductus, and an atrial septectomy if needed, combined with a Berlin heart VAD insertion. As demonstrated in this labeled schematic, showing the location of the cannula in the right atrium and the pulmonary artery, the ductal stent, and the bilateral pulmonary artery bands. Our results: 56 patients underwent stage 1 procedure with two deaths, or 3.6% mortality rate, and there were 0 additional deaths prior to 1 year of age. 9 patients underwent a hybrid procedure without a VAD with an operative mortality of 0, but with 1 death after a comprehensive stage 2. And 8 patients underwent a hybrid procedure with a VAD 3 died on VAD while awaiting transplantation, and 5 patients underwent successful cardiac transplantation. And finally, 3 patients underwent primary cardiac transplantation with prostaglandin used as a bridge. 2 underwent successful heart transplantation after 52 and 120 days, and 1 died while waiting after 293 days of therapy. If we look back at the flow diagram, this depicts our 54 out of 56, or 96.4% survival of standard risk patients surviving a stage 1 Norwood. All 9 patients with a hybrid survived. And as previously discussed, 3 patients underwent primary cardiac transplantation with prostaglandin used as the mainstay of their bridge to transplantation. And 8 patients underwent a hybrid with a VAD. Finally, this flow diagram provides additional data about follow-up. Of 54 survivors, 45 underwent a successful Glenn, 2 underwent a successful biventricular repair, 1 a successful heart transplantation, 5 are awaiting Glenn, and 1 is awaiting biventricular repair. Of the 9 patients undergoing hybrid without a VAD, 3 underwent a successful heart transplantation, 2 are awaiting heart transplant, 2 comprehensive stage 2 with 1 death, 1 awaiting a comprehensive stage 2, and 1 had a successful biventricular repair. And this shows the previously discussed outcomes of our 8 hybrid VADs, and also our 3 patients who had prostaglandin as their major bridge. Of these 8 high-risk patients with HLHS stabilized with a hybrid VAD, 5 underwent successful transplantation with a mean time on VAD of 162 days, and 3 died while awaiting transplantation with a mean time on VAD of 98 days. In summary, in 76 patients, our comprehensive approach to the management of patients with HLHS is associated with, I keep hitting the button, sorry about that. In summary, in 76 patients, our comprehensive approach to the management of patients with HLHS is associated with an operative mortality of about 3.5% and a 1-year survival of about 91% in all 76 patients. I think we're frozen. There we go. In conclusion, high-risk patients with hypoplastic left heart are poor candidates for Norwood palliation, can be successfully stabilized with pulsatile VAD insertion along with a hybrid palliation while awaiting cardiac transplantation. These patients may be extubated, enterally nourished, and optimized for transplantation while on VAD. VAD facilitates survival during long wait times, and these can be upwards of 6 months or more. In the final analysis, our comprehensive approach to neonates with HLHS and related malformations maximizes survival and optimizes the utilization of donor hearts. Thank you for the opportunity to present our data.
So, Mark, a very impressive series there. I have 2 questions. First, when you inserting the VAD and assisting the heart, how do you determine the bands, the PA bands? Because I think that's could be very tricky as you're coming off bypass and you're trying to, and you're transitioning and you're changing the flows and everything. I would think that that's a tricky issue. The second is there's a lot of hardware then in the chest, and is that a limitation sometimes in these patients?
So to your first question, the band size, we've actually changed over time. We initially cut rings of 3.5 millimeter Gore-Tex and wrapped them, but the support times were so long that we had to balloon a couple banded patients. So the patients who get out 4, 5, 6 months, we had a couple of patients where we had to balloon the pulmonary arteries. So we actually use a 4 millimeter band, and we band it down a little tighter than 4, so it's probably about 3 3/4. And that seems to work for us. So we choose 4 millimeter bands and make them a tiny bit tighter. Your second question with regard to hardware, it's the way you angle the cannula to sit off to the side. We use a graft extension on the outflow cannula, and you can tip that slightly over towards left chest. And if you cut the pericardium down on the left, you can allow it to fall a little bit. The heart will fall a little bit to the left. And the right atrial cannula can certainly be positioned so it's moving more towards the right chest. So it shouldn't be a problem. And we've done this down to 2.4 kilos.
Yeah, Mark, congratulations on a well-presented and really nice series. I had 2 questions. One, could you just elaborate on you mentioned the non-cardiac risk factors, but it was hard to read that box.
Yeah.
Cardiac risk factors. Could you, one, elaborate on those? And then the second question is, are you listing these patients or having them evaluated for transplant candidacy prior to putting in the VAD, or are you putting the VAD in and then seeing how they do and then saying, okay, this is a viable kid, let's list them? How do you guys manage that?
So we don't take the decision to go to VAD lightly because they are difficult to manage. And so the patients who get VADs they're really sick. Pretty much, they're typically pretty sick when we choose them. So they're ones that the cardiac factors, they're really sick. The non-cardiac, you asked me about the non-cardiac factors? The cardiac. So we had patient on ECMO. We've had patients on ECMO. 5 of the 8 were ventilated, and the other 3 were on significant non-invasive ventilatory support. They either have slight elevations in their numbers, but we don't. If they're in multi-system, Groves failure, we like to see some recovery before. We've had one patient on ECMO who had recovery of some function before we did this. So that's how we typically choose who's going to go on with cardiac risk factors. Whereas non-cardiac, it's patients who we do not think will tolerate bypass and a Norwood for other reasons.
I would just suggest, so obviously great series and showing us, we should all remember that the Berlin had never had a survivor of a Norwood that got a transplant and was discharged. And so some of your work has really pushed us to thinking about the smaller children. I will say that another way to not use the Berlin cannula is when you start getting really small, 2.5, 2.3 kilograms, is just to sew a graft onto the side of the PA and then just use a normal aortic cannula that you tunnel through and just use a normal venous cannula that you tunnel through the skin. At 2.3, they're not going to get up and walk around, so they heal. We have one right now that's 2.3 when we put it in, and another one that was 2.5 that we successfully got to transplant at home. So just when you start getting those to lower sizes, you can just use normal cannulas, or at least we have been able to do that successfully.
That's great. I think with bivalirudin now, it's been a game changer with clotting. I would worry about that with regard to clotting and stuff, but I think bivalirudin has been a game changer. And in this series, of those 8 patients, we only had 2 strokes, and they were both after 150 days of support, which was pretty remarkable.
What size grafts are you guys using for the cannulas? Or?
So we believe, that we flow them pretty high. So the cardiac index sometimes is 4. So, I put a 10, right, and a 2.3, right, that goes through a 3.5 graft. Mm-hmm. So. Thanks.
Mark, could you comment about PA growth? I mean, you have a VAD trying to stimulate PA growth.
Yeah, you had asked me about that, and we've not seen a huge problem with that. When I come back to transplant them, MPA is usually very dilated. Typically, you can take the bands off and you can dilate the PAs with dilators, and they just open right up. And so the PAs, the MPA is huge.
Well, thank you so much.
Thanks so much. I appreciate it.
Thanks.